we enter to the surgical approach of the hip joint. We must know some salient features of the anatomical of the hip joint. Articulation. Hip joint is a ball and socket type of synovial joint. The hip joint is articulation between the hemispherical head of the femur and cup-shaped acetabulum of the bone. The articular surface of the and deficient inferior in the acetabular notch. The cavity of the acetabulum is deepened by the presence of eyebrow cartilaginous ring called acetabular labrum. The labrum reaches across the acetabular notch and is here called transverse acetabular ligament. The articular surface are covered with hyaline cartilage, fibrous capsule attached on the hip bone to the acetabular labrum and on the femur to the intertrochanteric line in front and 1 cm medial to the crescent behind. Hip muscles anteriorly, rectus femoris, sartorius, also known as a tidal muscle. It is the longest muscle of the body. Iliopsoas muscle group, iliacus and psoas. Lateral muscle, gluteus medius, gluteus minimus. Gluteus minimus underlying the gluteus medius, tensor fasciae lata. 6 intrinsic external rotators. One is of pyriformis, another one is of quadratus femoris. Obturatus externus. Gemellus superior, gemellus inferior. Medial, adductor brevis, adductor longus, adductor magnus, pectinis, gracilis. Approaches to the hip joint. Anterior approaches. Anterior approaches are iliofemoral approach of Smith-Peterson, limited anterior, and somaral anterolateral approaches. Anterolateral approaches of Smith-Peterson, anterolateral approaches of Watson-Jones, modified Watson-Jones, lateral approach of Watson. Lateral approaches are McFarland and Osborne, Hardinge and Frank de Male, McLaughlin K. Posterior approaches are Austin Moore, also called a Southern Moore approach, Osborne, posterolateral approach of Gibson. Medial approaches are Rudolph, Fresson, Hoppenfield, De Boer, anteromedial approaches of Satspine and Gamedov. The intermuscular interval used in the anterior, anterolateral, and posterior. Example, anterior approach is the intermuscular interval between the sartorius and tensor fasciae lata. Anterolateral approaches are intermuscular interval between the tensor fasciae lata and the gluteus medius. Posterior approaches are Southern Moore approaches are split the gluteus maximus muscle. Anterior approach to the hip joint. Indication of the anterior approach to the hip joint. Open reduction of the congenital dislocation of the hip when the dislocated femoral head lies anterior superior to the true acetabulum. Synovial biopsies, intra-articular fusions, total hip replacement, hemiarthroplasty, excision of the tumors, especially in the pelvis, pelvis osteotomies, arthrotomy of the hip joint, anterior column of the fracture of the acetabulum, incision of the pin or nail in the femoral neck. Question of the patient. And the patient is supine on the table with a small sandbag beneath the affected hip joint. Incision, curvilinear incision start from the anterior half of the iliac spine to the ASCS, from the curve to it down to X2 at 8 to 10 centimeter. Internervous plane, superficial plane, sartorius. Sartorius is a nerve supplied by femoral nerve, and tensor fasciae lata supplied by superior gluteal nerve. The lateral femoral cutaneous nerve, also called as the lateral cutaneous nerve of thigh, pierces the deep fascia close to the intermuscular interval between the tensor fasciae lata and the sartorius. This picture shows identify the gap between the tensor fasciae lata and the sartorius by the palpation. Incise the deep fascia on the medial side of the tensor fasciae lata. Retract the sartorius upwards and medially, and the tensor fascia downward and lateral. The deep internervous planes lies between the anterior approach, rectus femoris, supplied by the femoral nerve, and the gluteus medius supplied by the superior gluteal nerve. And the deep layer of musculature consists the rectus femoris and the gluteus medius is now visible. The ascending branch of the lateral femoral circumflex artery must be ligated in this approach. Due to in this approach, the damage is now is the excessive blood loss during this approach. Detach the rectus femoris from both its origin, anterior iliac spine and superior lip of the acetabulum. The hip joint capsule now partially exposed. Retract the iliopsoas and medially also. The hip joint capsule is fully exposed. Detach the muscle of the ilium if further exposure is needed. Incise the hip joint capsule. T-shape or longitudinal incision are made. Proximal extension of the wound exposed to the ilium. Distal extension of the incision exposed to the anterior aspect of the femur in the interval between the vastus lateralis and the rectus femur. Advantages: excellent access to the anterior hip joint, good muscle function, if the surgeon stays within the limitation and employs sound post-operative care. Can be extended distally and laterally through iliotibial band for the features of lateral exposure. May be extended proximally and medially, then subperiosteally to expose the entire acetabulum. And in this approach, the main source of the bone graft material, ready to source of the bone graft material, relaxation of the gluteal muscle in case of high riding dislocation. Disadvantages: necessity for the prolonged production to avoid risk of late detachment of the TFL and gluteus muscles, gluteus medius, because the major muscle dissection. High incidence of heterotrophic bone formation, joint stiffness, injury to the lateral femoral cutaneous nerve, the disturbing dysesthesia of the thigh. Exposure of the medullary canal is limited. The following are the disadvantages of the in this approach. Lateral approach to the hip joint. It is commonly used for total hip replacement. It combines excellent exposure of the acetabulum with the safety during reaming of the femoral shaft. Popularized by Watson Jones and modified by Charnley Harris Muller. Uses are total hip replacement, hemiarthroplasty, open reduction and fixation of femoral neck fractures, synovial biopsy of the hip, biopsy of the femoral neck. Position of the patient. The picture shows the position of the patient. Position of the patient on the operating table for the anterolateral approach to the hip joint. Bring the greater trochanter edge of the table and allow the buttocks, skin and fat to fall posteriorly away from the operating plan. This picture demonstrates the incision of the anterolateral approach to the hip joint. Incision, flex the leg about 30 degree and adduct it. So that is lying across the opposite knee, both to bring the trochanter into the greater relief and move the tensor fasciae latae anterior. Make a 8 to 15 centimeters straight longitudinal incision centered over tip of the greater trochanter. The incision crosses posterior third of the greater trochanter before running down the shaft of the femur. Internervous plane. There is no true internervous plane for this approach since the gluteus medius and the tensor fasciae latae have common nerve supply. The nerve was superior gluteal nerve. This is a picture shows incision of the fascia latae posterior to the tensor fasciae latae muscle. Retract the fascia latae and the tensor fasciae latae muscle, which it envelopes anteriorly, revealing the gluteus medius and series of vessels that have crossed the interval between the tensor fasciae latae and the gluteus. Retract the gluteus medius posteriorly and the tensor fasciae latae anteriorly. Uncover the fatty layer directly over the joint. Bluntly dissect the fat pad of anterior portion of the joint capsule to expose it and rectus femoris tendon. Osteotomy of the greater trochanter. Osteotomy of the greater trochanter and reflected superiorly the gluteus medius muscle. The expose of the capsule, the joint capsule, is easily to using this approach. Reflect the osteotomized portion of the greater trochanter superiorly with the attached of the gluteus medius to reveal the joint capsule. The joint capsule may also be exposed to partial resection of the gluteus medius tendon from the anterior portion of the trochanter. Reflect the head of the femoris and the anterior portion of the hip joint. It's also helpful to the expose of the joint capsule. Incise the anterior capsule to reveal the femoral head and neck and the acetabular limb. If further proximal exposure is needed, they incise the fascial latae proximally toward the iliac crest and along the iliac crest anteriorly to facilitate the hip dislocation of the hip. The incision, the tight fascia latae and fibers of the gluteus maximus to expose the acetabulum, dislocate and resect the femoral head, placing 3 or 4 retractors around the lip of the acetabulum provides excellent exposure in this approach. How to enlarge the approach? Local measures like incising the fascia latae anteriorly or posteriorly. Extensive measures extending the skin, incision down to the lateral aspect of the thigh and splitting the vastus lataris, again to assess the lateral aspect of the femur. This approach cannot be useful extended proximally. This picture shows the extension of this approach. Extend the incision down lateral aspect of the thigh, incise the deep fascia and splitting the vastus lateralis. Line with this musculature, reach the lateral aspect of the femur. The next approach is lateral approach to the hip joint. Lateral approach to the hip joint. The direct lateral approach or a transgluteal approach allow the excellent exposure of the hip joint. It avoids to need the trochanteric osteotomy. Before the anterolateral approach, we need to expose the joint. We must do it a trochanteric osteotomy or incise the gluteus medius anterior portion. In this approach, only trochanteric avoids the trochanteric osteotomy. Indication: total hip replacement surgeries. Good approaches to the femur head. Position of the picture shows the position of the patient on the table. Position of the patient on the operating table for the lateral approach to the hip. Bring the greater trochanter to edge of the table and allow the buttocks and skin and fat to fall posteriorly away from the operating. Position of the patient and incision. Supine on the operating table with the greater trochanter at the edge of the table. This allows the buttock muscle and the gluteal fat to fall posteriorly away from the operating gun. Make a longitudinal incision centered over the tip of the greater trochanter in the line of the femoral shaft. Incision. Begin the incision 5 cm above the tip of the greater trochanter. Make a longitudinal incision that passes over the center of the tip of the greater trochanter and extends down the line of the femoral shaft approximately 8 to 8 cm. Internervous plan. There is a no to internervous. Splitting of the gluteus medius muscle and their own line the distal to the point where the superior gluteal nerve supply the muscle. The vastus lateralis muscle is also split in its own line lateral to the point where supplied by the femoral. This picture shows divide the deep fascia in the line of the skin incision, retract the facial gest to pull the tensor fascial latae anterior. Split the fibers of gluteus medius above the tip of the greater trochanter and extend the incision distal to the lateral aspect of the greater trochanter until 2 cm of the vastus lateralis also split. Develop the anterior flap and divide the tendon of the gluteus medius muscle to reveal the anterior aspect of the hip joint capsule. Enter the capsule using a longitudinal T-shaped incision to expose the femoral head and joint. Osteotomy the femoral neck using the oscillating saw. Extract the femoral head, insert appropriate retractors to reveal the acetabulum. Dangers of the approach. Superior gluteal nerves runs between the gluteus medius and the gluteus minimus muscle approximately 3 to 5 cm above the upper part of the greater trochanter. More proximal dissection may cut this nerve or may produce a traction injury. For this reason, insert a stay suture at the apex of the gluteus medius split. This will ensure the split does not inadvertently extend during the operation. The femoral nerve is the most lateral structure, anterior neurovascular bundle of the thigh, vulnerable to inappropriate placed retractors. The vessels injured in this approach. The femoral artery and vein also vulnerable, inappropriately placed the anterior retractors. The placing the anterior retractors injury to the femoral nerve or vein in this. The transverse branch of the lateral circumflex artery of thigh is the cut as the vastus lateralis is mobilized. It must cauterize during. How to enlarge this approach? The approach can easily extend distally to expose the shaft of the femur, split the vastus lateralis muscle in the direction of the fibers. This incision cannot be extended proximally. Proximally, it causes injury to the superior gluteal nerve. Advantages: improve exposure of the acetabulum and femoral neck, preserve the integrity of the gluteus medius muscle. Disadvantages: difficulty to revision surgery. In this approach, difficulty to revision surgery slightly increased blood loss comparatively to other approach. Hardinge modification. Direct lateral approach or transgluteal approach. Position of the patient. Patient was supine with the greater trochanter at the edge of the table. Make a posteriorly directed lacy J incision centered over the greater trochanter. The only difference in this before approach compared to the before approach, instead of osteotomizing the greater trochanter, incise the tendon of the gluteus medius obliquely across the greater trochanter, leaving the posterior calf still attached to the trochanter. This approach, the anterior gluteus medius tendon are cut and posterior gluteus medius tendon is still attached, carrying the incision proximally in line with the fibers gluteus medius, distally carrying the incision anteriorly in the line fibers of the vastus lateralis. Advantages of this approach: a greater trochanter, the bulk of the gluteus medius is preserved, allowing rapid rehabilitation. Posterior approach to the hip joint. The posterior approach is the most common approach used to expose the hip joint, popularized by Moore, and often it called southern Moore approach. Indication of this approach: hemiarthroplasty, total hip replacement including revision surgery, open reduction and fixation of posterior acetabular fractures, dependent drainage of the hip sepsis, removal of loose body from the hip joint when a dislocation has occurred, pedicle bone grafting, open reduction of the posterior dislocation of hip. Position of the patient. The picture shows the position of the patient. The patient is the true lateral position. The affected hip in the upper and upper end. Unaffected is the lower end. There is no true internervous plane. Split the fibers, the gluteus maximus. A procedure that does not cause significant denervation of the muscle. This picture shows superficial skin incision and incise the fasciae latae. Incision. Start 10 cm to distal to the PSA, posterior superiorly explained, and extended distally and laterally, parallel to the fibers of the gluteus maximus to the posterior margin of the greater trochanter. Then directed the incision 10 to 13 cm distally parallel to the femoral shaft. Expose the approach, expose and divide the deep fascia, separate the fibers of the gluteus maximus by blunt dissection. The first muscle layer. Retract the gluteus maximus to reveal the fatty layer over the short external rotator. So the picture shows retracted the gluteus maximus to reveal the fatty layer over the short external rotator. Push the fat posteromedially to expose the incision of the short external rotators. Note the sciatic nerve is not visible. It lies with the substance of the fatty tissue. Place your retractors within the substance with the gluteus maximus superficial to the fatty tissue. The picture shows A, B, C. A and B internally rotate the femur to bring the incision of the short external rotators of the hip as far lateral to the sciatic nerve as possible. The picture C, detach the short external rotator muscles close to the femoral incision and reflect the backward, laying them over the sciatic nerve to protect it. Insert the posterior joint capsule to expose the femoral head and neck. To gain additional exposure, cut the quadratus femoris and the tendinous incision of the gluteus maximus. Advantages: relatively stability of the operated hip, brief period of immobilization, rapidity with which joints may be opened or closed through the relative breadless plane. Excellent exposure of the posterior lip and posterior column of the acetabulum. Disadvantages: dependent incision with a tendency to dependent edema. Acetabular exposure is inferior compared to other approach. Increased postoperative infection, weakening of the posterior capsule of hip. So increased chance of dislocation. Postoperative period, increased chance of dislocation in this approach. Vascular damage. Only limited exposure of sciatic nerve is possibility. The sciatic nerve injury. Next approach is a medial approach to the hip joint. Medial adductor approach of Rudolph. In 908, he originally described the posteromedial approach. In 1939, he modified it to present anteromedial approach. Uses or indication: open reduction of the congenital dislocation of the hip. Approaches choice for lesions and lesser trochanter. Biopsy and treatment of the tumors to the inferior portion and femoral neck and medial aspect of the shaft. Psoas release, operator neurectomy. Disadvantage: incision close to the perineum. Disadvantages: limited exposure to the capsule of the hip joint, deep incision to vascular injury. The position of the medial approach of the hip joint: the patient hip flexed, abducted and external rotator. Osteology of the medial approaches of the hip joint. The medial approaches only to visualize the medial structures of the proximal femur, like a lesser trochanter and a medial part of the head of the femur and neck and pubic tubercle. In this region, when the lesion is occur, in this approach to rectify it. Anatomy of the medial approach to the hip: the eye is abducted and slightly flexed and external rotated. The plane of the superficial dissection runs between the adductor longus and gracilis. Superficial dissection inserts the deep fascia along the posterior margin of the adductor longus. Develop the plane between the adductor longus and gracilis. Deep dissection. Continue dissection in the interval between the adductor brevis and adductor magnus until you feel the lesser trochanter. Develop the plane between the adductor longus brevis anteriorly, gracilis adductor magnus posteriorly. Flux, abduct, external rotate to bring the lesser trochanter close to the skin. This picture shows the incision of the medial approach. Internervous plane. The superficial dissection does not exploit any internervous plane because of the both adductor longus or gracilis are supplied by same nerve and the nerve of anterior division of the operator nerve. And the more deeply, the plane of the dissection between the adductor brevis supplied by the anterior division of the operator nerve and the adductor magnus, adductor portion of the posterior division of the operator nerve and the ischial portion of the tibial portion of the sciatic nerve. This picture shows the intermuscular interval of the medial approach of the hip joint. Intermuscular interval between the adductor longus and gracilis is not an internervous plane because both muscles are innervated by the anterior division of the operator nerve. The plane is safe, however, because of the muscle receive the nerve supply proximal to the dissection. Picture A demonstrate. Develop the plane between the gracilis and adductor longus, superficial dissection. Retract the adductor longus and gracilis to reveal the adductor brevis with overlaying anterior division of the operator nerve. The C picture demonstrate. Retract the adductor brevis from the muscles belly of the adductor magnus to uncover the posterior division of the obturator. Now, note the lesser trochanter in the depth of the wound. In this approach, medial approach, danger point are many because of the more neurovascular structures are located in the medial aspect of the hip joint and thigh. Danger point 1, and the anterior branch of the obturator nerve lies on the front of the adductor brevis and neurovascular bundle of the graceless muscle. Danger point 2, posterior division lies the substance obturator externus, runs down the thigh adductor magnus under adductor brevis. Danger point 3, medial circumflex artery passes on the distal part of the psoas tendon. It is in danger if you try to detach the psoas without isolating the tendon, and cutting under vision is especially in children. Thank you.